This week on Heal Yourself Radio, we're going to be talking to Dr. Michael Mollo, who is an emergency room resident and a great personal friend of mine. And we're going to be talking about hopefully some tips that you'll never have to use on your own, but it's something that we always need to be prepared for, and that's a potential night at the emergency room. So Dr. Mike is going to be talking about that and some things that you can do to make that experience a little bit easier and a little bit better, and not just for you, but for the staff and the doctors and other patients as well. So tons of great information on this. Let us know what you think, healyourselfradio.com, and check us out on Twitter at Dr. Jonathan Chung and leave your comments with us there.
You're listening to the Heal Yourself Radio Podcast. Unleash the Doctor Within with your hosts, Dr. Jonathan Chung and Dr. Gregory Jean-Pierre.
Welcome to another episode of Heal Yourself Radio, where we talk about the things that you can do to best take care of yourself. And today I think we have a really important topic to cover because it's a real problem that no one wants to ever face, but it's something that we should always be prepared for. We're going to be talking about what to do if you ever run into a situation where you're in an emergency situation and you have to go to the ER. And to talk about that today, I got one of my really good friends to come on board with us. I have Dr. Michael Mollo. He is a resident physician at the ER department in the Carolinas Medical Center in Charlotte. And I've known Mike for a long time. He's a super bright guy. And he wanted to come on and share some valuable information for everyone today. Welcome to the show, Mike.
Hey, John. Thanks for having me on.
All right, Mike. So obviously I've known you for a long time, but why don't you give our listeners a little bit of background about yourself?
So right now I'm a second-year emergency medicine resident up here in Charlotte, North Carolina at Carolinas Medical Center. It's a university-affiliated hospital with UNC out of Chapel Hill. Sixth busiest trauma center in the U.S., so we see a lot of trauma, both blunt and penetrating. And we get a lot of sick patients as well from kind of our tertiary network in North Carolina. I've also worked in the ER systems in Orlando and up in the Northeast. So I've got kind of a varied experience between suburban ER and both an urban kind of fast-paced ER experience as well.
All right. Well, I want to talk about two big concerns that they're kind of a burden on our health system, and that's the two main situations we're talking about is people going to the ER for a situation that doesn't really need emergency rooms resources. And then the flip side is when people have some signs and symptoms where they need to go to an ER, but they're ignoring those signs and symptoms. So I want you to speak a little to that just to kick things off.
Yeah, that's really insightful, John. One thing I didn't really realize in medical school is how much primary care is involved in emergency medicine. And mainly that's a large portion of that's because of just the discrepancy that we have in primary care availability to people, especially without insurance. You know, primary care physicians and kind of the frontline doctors, so to speak, aren't, unfortunately, the availability and allure is not there in primary care medicine. So, you know, in the emergency department, we feel a big brunt of that. We take care of a lot of the underserved population, especially here in Charlotte. I think probably 80% of my interactions to 70% of my interactions in the ER are probably uninsured or kind of lower economic status. And that comes with working in a big kind of university system, big urban hospital. So because of that, you know, wait times are always going to be higher. You know, patient satisfaction goes down a little bit because, you know, you're just so busy, so swamped. You know, in the average shift, in a 10-hour shift, I'll see 30 patients. You know, and so 3 patients an hour, you can imagine, is a lot.
Yeah,
So,
for sure.
you know, as far as people who you know, whether or not to go to the ER, dealing with wait times, kind of those challenging things. You know, you kind of really intelligently said that our emergency rooms are really being inflated in volume. And a lot of the reason is because of kind of these primary care complaints. You know, someone has a really bad toothache and they don't have a primary care doctor or they can't afford to go to a dentist, so they come in the ER. One solution that we've come up with over the last 5 to 10 years is what's called a fast track or an urgent care portion of an ER, where we'll take care of things like toothaches and, you know, minor lacerations. just kind of a couple pro tips to the listeners that I've kind of come across in my time is that if you come in the morning in the ER, especially on a weekday, that's when you're going to have probably the shortest waits. The longest waits are usually, Thursday. I would say Friday, Saturday, and Sunday evenings. Friday and Saturday primarily because there's just so much trauma. People out drinking alcohol, getting in a car accident, stepping on glass at a bar. Just in general, there's a higher population volume that are out doing usually dumb things. So, if you have if you have some abdominal pain and or if you had some complaint that maybe wasn't urgent, like you had some flu symptoms or something like that, and you weren't in extremis or really urgently sick, then I think that's probably something you want to wait till for the morning to come in for. Now, on the flip side of things, a lot of people, especially I notice, these patients that come from like these rural areas or farmers or, they work outside as carpenters or something like that. And they tend to be real stoic people. They'll have crushing chest pain and they'll just kind of sit at home and wait around and say, oh, I don't want to go to the emergency department. I think in that situation, especially calling the ambulance will kind of accelerate your process. I mean, the big three complaints, the largest three complaints we get in emergency medicine is abdominal pain, chest pain, and back pain, probably in that order. And so, those are, especially the abdominal pain and chest pain, are two things that we really have a high sense of urgency for, particularly chest pain in our center. So, there's certain kind of red flag complaints that we're always going to kind of triage a little bit higher in the list. So chest pain and abdominal pain being two of those. And then obviously any neurological symptoms. So, acute onset of a severe headache or any neurological symptoms like, one-sided weakness, one-sided blindness, facial droop, problems with speech, things like that.
Definitely, and that's something that we cover a lot in our chiropractic practice is, especially if you have like the worst headache that you've ever had in your life and you've never had headaches before, those types of situations is definitely want to get it checked out in the ER, and then also an inability to urinate or go number two is also another situation that people want to pay a lot of close attention to and talking about going to an ER too. You don't want to ignore those symptoms at all.
Right, right, and exactly. And actually, I know John, you're a big CrossFit advocate and CrossFitter, and I just got back into it myself. I've been doing it since undergrad, and actually, just had an interesting case the other day of a guy who he was about our age, 30-year-old guy who was he had just been doing, I think, Grace, which is a workout involving some Olympic lifts where you kind of pick the barbell up at 135 pounds and lift it overhead. He was doing it at a heavier weight than possible, but this guy was like a train. I mean, he was a Clydesdale of a guy, real strong guy, and he had just had a vigorous workout, and he was walking out of the gym, and he turned his head and just felt an acute onset of just the worst headache of his life that was maximal in onset. And I think a lot of people, when they hear that story, the first thing you think about is an intracranial hemorrhage or a brain bleed, and that's actually exactly what the guy had. And I think that it can kind of take this time to make a point that someone easily hears that story and they go, oh man, well that was CrossFit's fault, like that's if this guy wasn't doing CrossFit, he wouldn't have had this brain bleed. And that was a good education point for me to take to my colleagues, being like, hey, these things happen. This gentleman ended up having an underlying AVM, an atrial venous malformation. Basically, he had aneurysm type. Vascular abnormality in his head that predisposed him to this, and just any exertional exercise is going to put him at higher risk for rupturing that vascular malformation. But it's just interesting because I think a lot of CrossFit gets a bad rap, and everyone this guy came to the ER and everyone was like, oh well, it's all CrossFit's fault and so on and so forth. But certainly was not the case, and the guy ended up doing great. But that's a classic example of what the common layperson should know is that it's one thing to have a headache after you work out, or if you have a headache that kind of starts minimal or kind of nagging you and then gets worse throughout the day. That seems more like a migraine or a tension headache. But the one classic symptom in a really serious headache is a lot of times these patients can explain to you exactly what they were doing. So this guy, he's like, I turned my head and I remember as soon as I saw my car and I looked at the license plate, the headache came on. So with a history like that, that's very classic for more severe, serious headache.
Definitely. So another thing that I've noticed a lot in the last probably 10, 15 years or so is the rise of urgent care centers. when are situations when people should say, all right, let me go check out the urgent care center, since my wait for the primary might be too long, and when should I go to an ER situation?
That's a great question, John. So I would say that, and I'm going to ballpark this just from my own experience. I would say 70 to 80% of all ER presentations, at least that I see in the kind of subacute and urgent care portion of the ER, can probably go to urgent care. So examples of that would be, low mechanism sports injuries. So, twisting your ankle, and maybe you just need an X-ray. You can bear weight on the foot, on your foot. There's no obvious deformity. Small lacerations are really good. If there's any tendon or vessel involvement, then that's something you want to go to the ER for. But any small laceration would be appropriate urgent care use. Any type of flu-like symptoms, so coughing, maybe you have a little bit of increased productive sputum or you're coughing more stuff up, but you have a low-grade temp, you're still able to breathe okay, you're not short of breath. Those are also good complaints for the urgent care setting. I would say, absolute contraindications for any urgent care would be head injuries or any type of high mechanism trauma, so car accidents where you weren't able to walk right away, or you feel like your heart rate's going quickly, you can't catch your breath. Those are all concerning. You should be evaluated at a trauma center. Any head injury, a lot of these urgent care centers don't feel comfortable handling head injuries. And even though, most of them are going to be absolutely fine and not even need a CAT scan, I would say that don't even waste your time going to an urgent care because a lot of times they're going to send those over to us. If you have any significant medical history that, the lay kind of average generalized practitioner is not going to be familiar with. So weird genetic disorders, any heart history, any history of, out of or poorly controlled chronic medical conditions like diabetes or hypertension, I would say don't waste your time at the urgent care either, because a lot of those practitioners sometimes just feel uncomfortable handling those complaints in the urgent care setting. But, even myself, if I had a bad ankle sprain or I had a small laceration, I actually broke my nose in medical school and I ended up going to urgent care for that too, because a lot of those can be managed medically or in an outpatient setting. So I would say, the urgent care is really great. And the reason we've seen so much of them lately is because emergency physicians and internal medicine physicians are opening up urgent cares to try to deload some of the volume that comes into the emergency department. So I would say any complaint that's kind of non-urgent, or, at least, you don't have the big red flags of, troubles using the restroom, bad headache, any type of trauma, chest pain, those things are more reserved for an emergency room setting. But any, kind of ambulatory complaint, as we say, could definitely be seen at urgent care. And the other thing is, if you go to the urgent care and they're not comfortable or there's more going on than you think, they can always transfer you directly to an ER and, kind of quote unquote skip the lines, so to speak. So
Nice. Okay. Well, obviously, no one ever makes plans to be in an emergency room at any given time. But are there any tips that you have for people that when they are already in that situation, they're on their way to the emergency room? Is there anything that they can do to help make that experience a little bit more bearable, a little bit easier on them,
yeah.
just to survive it better?
Yeah, good question, John. I think a lot of it falls on us as practitioners. One thing we have to keep in mind is that this is the worst day of this person's life when they come to the emergency room. In most cases, someone's coming in and they have chest pain, they find out they're having a heart attack, or someone comes in, they're weak, and they find out they have a stroke. It's on us to remember it's the worst day of that person's life. So really, being empathetic, keeping them informed. The number one feedback that we get as practitioners is that patients want to be informed on what's going on. No one wants to be left in the dark. So it's our job to keep patients informed and then be empathetic to their situation, remembering that, when I go in for my shift, it's just another day at work for me. But for this person who just got in a car accident, or who has a big laceration on their head, or even just, had something, minor trauma or minor medical complaint, like they may have never experienced abdominal pain or headache like this before. So it's on us to keep empathetic to that. I would say on the patient side of things, I hate to belabor this point, but, we the emergency room is a very, very busy place. We see a lot of patients, but just because we haven't stopped in a while to see you, or just because, we only went in for 2 minutes to quickly examine you and then leave the room, it doesn't mean that we're not thinking of you. It doesn't mean that we haven't started your workup and that we're not working things up kind of behind the scenes, so to speak. So I would just say, you have to be patient when you come to the emergency department just because it's such a high volume place. But the other thing I would kind of plan for, these are just kind of off the cuff things, is bring your cell phone charger if you end up in the ER. There's nothing worse than a patient coming to the ER, their cell phone dies, they end up having to get admitted to the hospital for a medical complaint, and they don't have a phone charger. I mean, these are all kind of stupid common sense things, but it's kind of maybe something you wouldn't think of. I've seen patients bring books in, their laptop. Um, and the other thing is, utilize your nurse. Nurses in the ER are great, and they do a really good job of keeping the patient informed when we're unfortunately busy sometimes. So, utilize your nurse, utilize your healthcare techs to keep you informed and help you out too. And don't be embarrassed. That's the other thing. A lot of people don't come to the ER because they're embarrassed. Like, man, I'm only 28 years old and I have chest pain. Like, I don't want to go to the ER for that. It's probably nothing. A lot of people either try to talk themselves out of it, or they're in denial about their symptoms. Hey, did I lose you?
A little bit. We lost you right at the point where you said a lot of people are in denial about their symptoms.
Oh, yeah. So just kind of going back. So a lot of people, are in denial about their symptoms, like, oh, this chest pain. They try to rationalize it, like, oh, it's nothing. I ate some spicy food or this or that. But I've seen 28-year-olds come in with massive heart attacks. I just described that healthy 30-year-old who had a brain bleed. We see these things all the time. So it's one thing to be a hypochondriac and think, oh, I stubbed my toe. Do I have a blood clot? Am I going to, die of a massive pulmonary embolism? I mean, that's a little extreme. But on the other end of things, you shouldn't ignore worrisome symptoms, especially if they're nagging you and they're bugging you and you don't have a primary, or it's the middle of the night. Just come to the ER. I never judge people for coming in, just no matter what the complaint is. So I would just say, if it's enough to keep you up at night or you're anxious about it, then you should just come and get checked out.
Definitely. I would 100% agree with that because it's better to have a trained physician tell you that there's nothing wrong with you than to have that worst case scenario happen where you just dismiss it and then it turns out to be something serious like a stroke or a heart attack or something along those lines.
Right. And the other thing is, emergency medicine is becoming, it's such an evolving field. It's only been around for about 40, 45 years of actual ER trained physicians. And we're picking up a lot more in the emergency department now. So, even if it's, you have some weird underlying conduction abnormality in your heart, or you have some weird, vascular malformation that I mentioned earlier, we're able to pick these things up in the ER now, and they're less likely to get missed. So, we can do a lot more of that primary care initial workup type thing in the ER these days, which is kind of nice as well.
Is there like pieces of information that help make your job easier if the patient has it? So, for example, if they could have their phone on them and they have like a list of medications or any type of information that they could keep with the person that you think is just good for the normal person to carry around just in case the emergency thing situation happens.
Yeah, I would say two things. The first is, don't lie about your medical history or about your social history in particular. We see people all the time who come in and they're embarrassed to say that they use marijuana or cocaine, and that completely changes our management. We're not the cops. So I don't care morally or personally if you used cocaine last night when you were partying or whatever. Obviously, I don't advocate for it, but if someone comes in with chest pain and they've used cocaine, it's a completely different workup and a completely different approach than if someone just had chest pain out of the blue, or, if someone took some over-the-counter drug and they took too many of them. Maybe they were trying to go to sleep last night and they took 10 Benadryl, and now they're coming in and they have these weird neurological complaints. It's important for us to know those things. So, we've seen it all, we've heard it all. I pass no judgment on any patient for anything they've done before. So I would say the first most important thing is just don't lie and be upfront with your physician or your provider. The other thing I would say is, if you take any medications, try to bring your either medication list, the bottles, or the dosages, because that's important too. If a good example of that is if someone's been improperly or incompletely treating an infection by taking their antibiotics not as scheduled, then that puts them at risk for an antibiotic resistant organism. And then, it's also, you can kind of get a good gauge of people, how healthcare literate or how kind of naive to healthcare they are. If I have a patient who has a chiropractor and a physical therapist and a primary care physician, I know they're going to be more involved in their health and be more knowledgeable about their health. Whereas if I have someone who comes in and has never seen a physician before or any type of healthcare provider. So those are all important things to know. It's anyone, and John, I know you're a big advocate of this. Everyone should take part in your healthcare. You shouldn't just leave it up to your healthcare providers to do everything for you. You got to take the initiative to take your medicines or to exercise, to follow up with your appointments. So I know I'm
Good.
kind of preaching to the choir here. If you're listening to this podcast, I'm sure you're like a grade A citizen.
Yeah, for sure. I mean, we definitely have an educated listenership, but you're hitting on some things that, even I didn't think about before. So you're definitely providing some valuable insight for people. So we appreciate that. What's Do you have some interesting stories that you like to tell? I don't want to put you on the spot for anything here or get you in trouble with anything, but
Oh, that's all
anything.
right. Yeah, and it's funny, up here at CMC, we see it all. We have a very, very big catchment area. I mean, the greater Charlotte area is about 1 million people. Like I said, we're the sixth busiest trauma center. And I would say, it's just never like I can just go into last week and I was walking out of the hospital after a 12-hour shift. And I'm literally just walking through the ambulance bay and I see this car pull up and kind of halt to a stop. And I see this really frantic young Hispanic guy get out of the car and kind of, he's motioning to me with his hands. And I look in the back seat on the window there, and luckily there's a kind of nurse around with me. And there's a lady who's evidently pregnant, kind of squatting in the back seat. The nurse brought me out some gloves, and we're kind of all there. And whenever pregnant people show up in the ER, especially full-term pregnant women, everyone kind of gets a little excitable. So, within 30 seconds, we had probably 20 ED providers and staff out there. And I ended up delivering this lady's baby in the backseat of her car because she was crouched over wearing gym shorts. And I could see kind of what looked like the out silhouette of a head in her gym shorts. And when I pulled off her gym shorts to try to get her exposed and do an exam, the baby's head was right there, and she was delivering pretty precipitously. So that was kind of funny. We delivered the baby right there in the back seat. I clamped and cut the cord in the back seat of the car. We got mom inside. Baby did great. No problem whatsoever. She was full term, luckily. We got her inside and, delivered the placenta. Mom did great too. So, it's just one of those things where you never know what you're going to see or what you're going to come across. So never a dull moment. You can hear a fire truck in the background right now, but never a dull moment at the hospital. And like I said, we just try to keep in mind that you can't fault people. I heard some people say, "Oh man, I can't believe this lady waited so long to go to the emergency department." But this is exactly what we're talking about, John. She had called someone, she had called a provider or a PA or an NP or something on the phone who worked for the OB clinic that she went to, and they said, "Oh well, you could go to the ER if you want, but it's up to you," and this and that, and kind of left it up to her instead of being a little bit more specific and saying that, "Hey, if your contractions are this, or if you really feel uncomfortable, you should just go to the ER." So kind of an unfortunate chain of events that ended up turning out fine. But I think it's important to kind of touch on this topic. And, it's people, I think, just to make a final point, I think people are embarrassed or they're nervous or they're in denial, or they just, when they're worried about an emergency, they think, well, if I don't go to the ER, I can't get diagnosed. And if I don't get diagnosed, then people want to be in denial, or, the whole ignorance is bliss thing. And I think that's the wrong approach. So.
Definitely. You got some great stories. I know you've shared some of them with me before, but that's definitely an awesome one where I'm glad this is one of the ones that turned out great for the patient and the new patient too.
Yeah, me too.
Where do you see the future of emergency medicine going?
Well, John, this is a funny question because I remember, so I started out as an emergency department scribe, which is really just kind of a glorified secretary doing some of the doctor's paperwork. And that was in 2008, 2009. And I remember at that time talking to a physician and just being like, hey, where do you think healthcare is going to go in the next 10 years? And he said something that really stuck with me. He's like, when Reagan was in office and they did the whole Medicare, Medicaid, revamp, everyone's like, well, medicine's going to be so different now, and it's going to be so much worse or so much better, and so much is going to change. And he said 20, 30 years later, nothing really changed. And I remember that pretty vividly because now I'm, 7 years later, something like that. And really not a lot has changed, with the whole Obamacare thing. Everyone's like, oh, the ERs are flooded before and they're not going to be flooded anymore because people are going to have primary care doctors, or then there's the other camp who says, oh, well, no one's going to have insurance because everyone's going to opt out and can't afford Obama's high premium and high deductible plans, so everyone's going to go to the ER. Well, and honestly, it doesn't seem like it's made much of a difference. I mean, people are coming to the ER just as much as ever before, and I think from an ER standpoint, the people are always going to be sick. There's always going to be underserved populations, and they're going to come to the ER. So I think from an ER standpoint, I think not much is going to change. I think hopefully, the point of this whole Obama thing was to try to get more access to primary care medicine, and I really hope that happens. I think it's a little premature to see now, but I hope in the next 5-10 years we have more access to primary care physicians.
Awesome. And a little
I
bit
also
of,
think one more point. Sorry. So I also think one thing I've seen in the last handful of years is that the physician assistant and nurse practitioner population has skyrocketed exponentially. So I think we're going to start seeing them doing more primary care type work to try to unload. I wouldn't be surprised if one day we see urgent cares run by PAs and NPs.
oh, definitely. I definitely see the writing on the wall from for that trend happening right now too. And I've seen I'm pretty friendly with some very bright PAs and very bright NPs, so I feel confidence in that population growing too.
Yeah.
So just some questions about you. And you're a guy that you're pretty fit. You do CrossFit. What are some other things that you do to help make you a highly functioning ER doctor?
Yeah, and so admittedly, since starting residency, I definitely have fallen off the curve a little bit as far as my fitness goes. I was real big into CrossFit, doing it, probably going 4 times a week on average, and trying to do like little competitions in the neighborhood and trying to eat pretty well. And then, residency, unfortunately, when you work 80 hours a week, it's hard to keep up your fitness. So my first year was pretty tough out, but this year I've done a better job of kind of buckling down and making it to classes. I think, the important thing it's so easy to fall into the trap of just kind of eating junk when it's around, especially in the hospital. We got sodas sitting around, we got crackers and cookies, and the nurses are always bringing stuff in, or patients are bringing things in that are really unhealthy. So I think kind of resisting that temptation to eat that brownie. you know my personal primary care physician made a really good point to me that's really stuck with me, and he said, don't waste your calories on meals you're not going to remember. So, if it's Wednesday afternoon and you're between like eating a sandwich or eating a salad or going to Chick-fil-A or Wendy's or McDonald's or eating a piece of pizza, like choose the salad in that situation. But if it's Saturday night and you're with your friends and you're going out to dinner, like don't be embarrassed to, get the steak with all the fixings or get a large fry or something like that. And that's kind of how I've approached my life as of late. So trying to, not be crazy and be super paleo and really let every calorie control my life. But on the other hand, just everything in moderation and making the meals that are memorable, kind of cheating on those, but otherwise trying to eat healthy and then get my exercise in, obviously.
Definitely. And obviously, ER can be, a high stress job for sure. What do you do to kind of de-stress and unwind from a work day or from a hard week?
I think the most important thing is sleep. We really undervalue sleep, I think, in our culture. And there was just a study that came out actually that showed that people that work the night shift, so third shift, it's considered a class 1 carcinogen. So basically, if you're working night shift, you have an increased cancer risk. And the other interesting thing now that they're coming out with, and I'm sure you're interested in this research and literature, is that sitting might be as much of a cardiovascular risk as smoking. So the new phrase that everyone's saying is sitting is the new smoking. So I think importantly, staying active, even when you're at work. If you sit at a desk all day, trying to make it a point to get up, move around. I know in the ER I barely sit, so that's helpful. And then really valuing your sleep. High quality. I'm doing my focus of research is actually in sleep. I'm doing a big IRB approved project this year where I'm analyzing all of the interns in the emergency department program with actinographs. So it's these actigraphs that, basically equivalent of a Fitbit. It tracks movement. So it's actually tracking these young physicians' sleep at night. So whether they're on an irregular schedule where they're working overnights or they're switching from days to nights or they're working 28-hour shifts, 16-hour shifts, or whatever, we're going to be tracking their sleep throughout the year and then doing a big compiling all the data and seeing how much sleep actually affects them. It's pretty interesting. We're giving them little reflex tests while they're at work too, and then trying to correlate, if sleep deprivation really can impact performance, which, we anticipate it will, but we're trying to objectively define by what degree. So it should be some pretty interesting stuff, and maybe we'll talk about it, when my research is done.
Definitely keep me updated on that because that's something that I'm reading a lot of interesting blogs on from different PhD scientists and different physicians, and
Yeah,
it's
yeah.
some really cool stuff going on there. And it's such an easy thing for people to fix. Well, I guess not easy, but it's such a simple idea that you can fix so much in your health just by sleeping better.
Yeah, yeah, it's the easy things and the simple things that we really often neglect or don't think about that can make all the difference.
Last question. What are some of your favorite books, websites, publications, resources that make you a better doctor and make you a better, I guess, healthy human being?
Yeah, that's a good question. I rely pretty heavily personally on blogs. I think blogs are pretty great because you can get a conversation going with a physician or a provider that's across the world from you, and a lot of especially the critical care emergency medicine literature. There's a lot of good what we call foamers. It's free open access medicine. So if you ever look up the hashtag FOAMmed, FOAMEM, that kind of thing on Twitter. People in that who are experts in the field are always kind of tweeting and blogging about those kind of things. So I'm really big into websites, online journals, and blogs, and that's how I get a lot of my information. I think in this digital age, we have so much access to so much great information. I think we need to take advantage of it.
Awesome. Great, Mike. Well, if you have anything else that you want to plug or find out, or if you have any websites where people want to find out more about you or what you're doing, this is your time to share.
Yeah, so my personal residency, we have a website where we have some more information about our hospital and kind of the research we're doing here. It's cmcedmasters and .com, and on there you can kind of see our program, what we're doing. We're doing some pretty interesting research. We do a lot of research in pre-hospital stuff, sleep deprivation. We do a lot of research in pulmonary embolism or blood clots in the lung, and do a lot of interesting that kind of thing. If you're ever in Charlotte, North Carolina, I hope I don't see you in the ER. I hope I see you in the street or at a restaurant or something. And thanks for having me on the show, John. It's been fun.
Thanks. It was